Hi there! Now that we're in crunch time for our summer NCLEX testers, we're calling back some of our greatest hits. Today we're going to focus on ECG interpretation with a lecture and a question drill. Starting now. Hello everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha and I am so excited to be back with you all today. So today we're going to be covering one of our most requested topics, and that's ECG interpretation. So we're going to talk about dysrhythmias that are mentioned on the NCLEX test plan and walk through what these are going to look like on an ECG strip, our causes of the dysrhythmias, and our treatments as well. So we're going to cover 5 different rhythms today. So make sure you look out for those. A couple of housekeeping things before we get started, but follow us at UWorld Nursing for more information on all of our live sessions, so you don't miss any of our future content going out in the next coming weeks. This live will be on demand after we're done on both all of our social channels. I personally find our YouTube the easiest channel to search in case there's something specific that you're looking for. As always, drop your comments, your questions, and your answers to today's questions into the chat. We have Nurse Jackie moderating today, so if you don't have any questions, just stop by and say hi at the very least. So with that being said, let's go ahead and get started today. Alrighty, so we're going to start with something a little bit different than we normally do, and we're going to check back in with that NCLEX test plan. So we brush on this every now and again. It's our good old friend, but it's what's going to be guiding our discussion today. So we've talked about the test plan several times in these live sessions, but it's been a little bit. So a quick refresher that NCSBN, the National Councils of State Boards of Nursing, is the organization that creates the NCLEX that you all will take. They have a test plan available on NCLEX.com, pretty simple, that gives you a blueprint or a study guide, so to speak, on what you need to know to prepare for the test. So in the client needs category listed in the test plan, one of our main categories is something called physiological integrity, and a subcategory of that is physiological adaptation. Now this will make up between 11 and 17% of the NCLEX that you all get. So if we break things down one more level, we get a topic that's called hemodynamics. In this section, it's an activity statement I'm going to read you guys that shows you exactly what you need to know. So first, identify cardiac rhythm strip abnormalities like sinus bradycardia, premature ventricular contractions or PVCs, ventricular tachycardia, atrial fibrillation or AFib, and ventricular fibrillation or VFib. Another one of the statements here says intervene to improve client cardiovascular status. Examples include initiating protocol to manage cardiac arrhythmias and monitoring pacemaker functions. So knowing this, we're going to cover those 5 dysrhythmias that the test plan specifically mentioned, so we know what as nurses to do in these situations. But before we do this, a quick little refresher on ECGs. We're going to cover normal sinus rhythm. That way we understand what our baseline is so we can more easily identify our irregular readings. Alrighty, so an ECG is a visual representation of the electrical activity of the heart. So typically strips that you see will be 6 or 10 seconds. So you all know today the strips that we're going to be showing you are 10-second strips. So I'm going to say it again, they are 10-second strips that we're going to be using as examples, which means if you're trying to get the beats per minute or the heart rate, we're going to multiply that number of beats by 6 to give us 60 seconds or 1 minute. But you can tell this because our 10-second strips, each little tick represents 0.2 seconds, and each of the darker squares are going to represent 1 full second. So if you count across the whole strip, there are going to be 50 of those little boxes or 10 of the darker boxes, which means 10 seconds in full. The data points that these ECGs use are letters as well. So we see P, Q, R, S, T. Sometimes you'll see a U, but we hope we don't see a U. So P, Q, R, S, T are what we will typically see in normal sinus rhythm. That P wave represents the depolarization or the firing of the atriums. We know we have 2 atriums in the heart, the left and the right. The PR interval is the time it takes for that depolarization to happen. Then we have something called the QRS complex, that big triangle, the big jump. This represents the depolarization or the firing of the ventricles. And again, we have a left and a right ventricle. Remember that our ventricles are bigger than our atria. So the visual representation of the electrical activity of the ventricles are going to be bigger. It's that electrical force to squeeze the ventricles. It's going to take more than it does for the atrium. The T wave represents the repolarization of the ventricles or the relaxing of the ventricles. So in quick summary, this all goes alphabetically. We think of our atria before our ventricles, A before V. P wave is atrial depolarization. QRS complex is ventricular depolarization. T wave is the ventricles relaxing. And again, the ECG is the visual representation of this electrical activity all put together. Alrighty, so with that being said, let's go ahead and check out our normal sinus rhythm. Again, it's always great to get our baseline so we can identify where we're having dysrhythmias or where things look irregular. Excuse me, sorry. So let's start with rhythm. The rhythm here is going to be regular. Again, it's normal sinus rhythm, meaning all of our essentials are going to be present and they're going to be predictable. So we have a P wave before each QRS. We'll have a ratio of 1:1, so 1 atrial contraction for every ventricular contraction. The PR interval, or the time it takes for those atriums to contract, is going to be less than 5 small squares, so it's going to be between 0.12 to 0.2 seconds. And the QRS interval is the time it takes for the ventricles to contract. This is going to be less than 3 small squares, or 0.12 seconds. A quick tip is that QRS is 3 letters, so it should be 3 squares, and we can remember 3 and 3. Lastly, our rate is going to be between 60 to 100 beats per minute because that's our normal range. We can measure from R to R here. So in this 10-second strip, we have 14 Rs. So we multiply that by 6 to represent 60 seconds or 1 full minute, which gives us a heart rate of 84 beats per minute. 84 is right there in the middle of our 60 to 100 normal range. So it's a normal rate. Again, this is normal sinus rhythm. Alrighty, and anything below that would be bradycardia, anything above that would be tachycardia. So speaking of that, let's go ahead and pull up our bradycardia image, excuse me. So sinus bradycardia, this is going to be our first dysrhythmia. We're going to start out on the simple side, so we'll check in with sinus bradycardia, and this largely is going to look exactly like that normal sinus rhythm. The only difference is that it's slower. So in sinus bradycardia, our SA node, which is what initiates the electrical activity of the heart, is going to be firing slower or less than those 60 beats per minute. We can tell this by counting those R's. So again, 10-second strip, we have 9 R's. So we multiply that 9 by 6 to represent 60 seconds or 1 minute, which gives us a heart rate of 54 beats per minute. Again, our normal range is 60 to 100. 54 is below that, so we know it's bradycardia. But again, all the components of regular sinus rhythm are present. So we have a P wave before each of our QRS complexes, meaning we have a ratio of 1:1, 1 atrial contraction for every ventricular contraction. The PR interval, or the time it takes for the atriums to contract, is going to be less than 5 small squares, or that 0.12 to 0.2 seconds. And our QRS interval, or the time it takes for the ventricles to contract, is going to be less than 3 small squares, or 0.12 seconds. Again, QRS is 3 letters. So we think of 3 squares, 3 and 3 is how we remember that. Alrighty, so that one's not too bad so far. But what are some of our causes of bradycardia? Go ahead and drop these in the chat too. I want to keep you guys engaged. Let us know. Alrighty. So causes of bradycardia include some of our basic physiological causes, things like age. So our SA node actually slows down as we age. Sleep can also be another cause. Our oxygen demands are lower when we sleep because we're not exerting ourselves, we're just laying there asleep. So our heart rate in turn will also decrease. Things that also can affect this are athletes and people who are in really tip-top shape, are in great cardiovascular health. These clients will have stronger hearts, resulting in a slower heart rate. Essentially, our heart beats slower, but it's getting the maximum ejection fraction with each pump, so it's working more efficiently. I remember I read something about Lance Armstrong in his prime, and his resting heart rate was like in the mid-30s beats per minute because he was in such phenomenal shape. So again, sinus bradycardia is not always a bad thing. Other causes can be things like medication the client is already on, like a calcium channel blocker, a beta blocker being our LOL medications, and digoxin. These are all designed to slow the heart rate, but we can go beyond what's therapeutic and slow it too much, putting us into sinus bradycardia. Other things that cause sinus bradycardia will be conditions like coronary artery disease, sick sinus syndrome, which can affect the sinus node's function. Other conditions like hypothyroidism. In hypothyroid, we have that slow metabolic function, that low and slow function, which can slow our heart rate in turn. Also, things like increased intracranial pressure, or ICP, manifests as Cushing's triad, which you all may be familiar with. Cushing's triad is 3 separate things: hypertension, or high blood pressure, bradycardia, or low heart rate, paired with irregular respirations, and this is due to pressure on the heart and the respiratory centers of the brain. So a lot of different causes for bradycardia. All of them are not necessarily bad. Some of them can be just because someone is in such good shape with such an effective beating heart. But treatment, typically we're only going to treat this bradycardia for our symptomatic clients. So it can be asymptomatic, like for those athletes, for those Lance Armstrongs and Michael Phelps, but it can also be symptomatic. When it gets symptomatic, that's when we would treat the clients, and these symptoms are going to be things like dizziness, syncope, which is episodes of fainting, or dyspnea. So drop in the chat what some examples of treatment for bradycardia will be, and I'll go ahead and jump into them so you can see if you are right or not. But examples of this treatment will include making sure we identify and treat the underlying cause. In a lot of cases, this may be holding a certain medication. We talked about how calcium channel blockers, beta blockers, and digoxin all slow the heart rate. They can slow it down below therapeutic levels. In this case, we would want to hold the medication and not give it to the client. Beyond that, once we figure out the cause and hopefully remove the offending agent, our first line treatment is going to be atropine. So this will increase our heart rate. I always remember atropine for bradycardia because ATS is like get at it. It gives you a little bit of a boost. So that's a good way to remember it. Our next step as we escalate would be temporary transcutaneous pacing, which is kind of like an external pacemaker. This would be used until an actual pacemaker can be implanted, which leads us to our ultimate fix. But a pacemaker essentially takes over for the electrical function of the heart. It generates that electrical stimulus to regulate the heart rates. So in summary of treatment, if the client is symptomatic, we will hold medications, give atropine. We then escalate to the potential for temporary transcutaneous pacing until we can implant an actual pacemaker. So with that being said, our next dysrhythmia is going to be a PVC, or a premature ventricular contraction, not a PVC pipe, just in case you were curious. So essentially what happens in these PVCs is exactly in the name, premature ventricular contraction. So our ventricles fire prematurely or at the wrong time. So normal conduction of the heart starts in the SA node, works to the AV node, goes to the bundle of His, and then the bundle branch to the Purkinje fibers. What happens in PVCs is somewhere after that AV node, things go a little bit awry. One of our checkpoints fires out of order prematurely. And typically 1 PVC is generally not going to be something we're too worried about, but 3 or more PVCs is where we start to get a little bit more worried, because this can lead to ventricular tachycardia, or VTAC, and we know that VTAC has the potential to progress into ventricular fibrillation, or VFib, which is a life-threatening dysrhythmia. Alright, so let's talk about what PVCs will look like on an ECG strip. You all can see the ECG that we have displayed on the slide, but PVCs will look like a variable heart rate, so that R to R interval is not going to be consistent. It's not going to be a consistent rate. We'll also have an irregular rhythm, which means the transition from atrial electrical activity on the ECG to that ventricular electrical activity on the EG will not be a smooth transition. So this irregular rhythm will look like a hidden P wave in the QRS, essentially like an out-of-sync jolt in the ventricle is going to hide that P wave from us. And since our P wave is hidden, we're not going to have that measurable PR interval. We can't have a PR with no P. The QRS interval will also be wide and distorted. Remember that QRS, we have 3 and 3, it's 3 letters, so it should be less than 3 small squares on the ECG. So a QRS greater than 3 small squares will be indicative of a PVC, or a premature ventricular contraction. Alrighty, so let's get into some causes of PVCs. If you all know what a cause of a PVC is, go ahead and drop it in the chat. Even if you just know one, no worries. We're always excited to hear what you guys are learning and what you guys think. But in the big picture, when we think of our causes for premature ventricular contractions, again, the hints are all in the names, we think of ventricular irritability from structural damage to the heart or maybe a lack of oxygen to that heart muscle. So we can think of afflictions like a myocardial infarction or MI, coronary artery disease, cardiomyopathy, problems with valves, heart failure, and really anytime we've operated on the heart as well, which a common one here would be like a cabbage. These are all risk factors for things that we can see a PVC from afterwards. Other causes include things like electrolyte imbalances. So the big electrolyte we worry about when it comes to the heart and our cardiac muscles is potassium, but we can also see effects from changes in our magnesium and calcium balances. Anything that's a stimulant, so anything that's going to make us feel overly excitable, substances that we love like caffeine. I know when I was in nursing school, I hit that Celsius pretty hard. These can actually cause PVCs, as can alcohol and nicotine. These all cause an increased adrenergic state, meaning our adrenaline is higher. So stress, anxiety, exercise, all of these can also stimulate us and make us more likely to experience PVCs. And in that same vein, hyperthyroid can also be associated with this. So remember, we talked about hypothyroid and sinus bradycardia because that's low and slow. It can slow the heart rate, i.e. bradycardia, whereas in this case, hyperthyroidism is an increased metabolic state. It's high, it's that fight or flight. It will increase our heart rate. This can also cause PVCs. On the oxygen side of things, we can see things like hypoxemia that causes PVCs, and this can result from sleep apnea or even a client with COPD. So our treatment now, what are we going to go ahead and do to these clients with PVCs? So most of the times when you are dealing with PVCs, it's just the occasional PVC and the client will still remain asymptomatic. At most, the client may feel like their heart skipped a beat or maybe there was a little palpitation. However, we touched on how multiple PVCs have the potential to progress to VTAC, ventricular tachycardia, and ventricular fibrillation or VFib. This can also happen when we have something called the R on T phenomenon. So what happens with this essentially is during the time when our ventricle is relaxing, an electrical impulse is going to fire. This can trigger ventricular tachycardia or ventricular fibrillation. So in saying all this, the treatment for PVCs is going to kind of spread the spectrum of emergence. So a client who is asymptomatic would just see occasional PVCs. We're going to monitor, report any changes like an increase in the frequency of these PVCs. However, if the PVCs make the jump to VTAC or to VFib, God forbid, then we will treat based on those dysrhythmias, which we're going to cover those in a second. Somewhere in the middle is correcting the underlying cause, especially if it's related to electrolyte imbalance or hypoxemia from not getting enough oxygen, or we'll try medication like a beta blocker to help to relax that heart. Alrighty, so moving on to dysrhythmia number 3, that's going to be ventricular tachycardia. And we've kind of alluded to this because PVCs, of course, have the potential to progress to VTAC, but now we're going to cover it on its own. So this is where we get into those more dangerous, our kind of scary dysrhythmias. So VTAC happens when we have 3 or more PVCs in a row. It tells us all in the name. We have a speed problem, tachycardia, with our ventricle. So essentially the ventricle takes over as the pacemaker for the heart. So again, it looks like exactly what the name says, tachycardia. We're going to expect a heart rate that's greater than 100 beats per minute. But what we're going to see is just a bunch of QRS waves that are irregular. And again, you can see this in the ECG strip that we have displayed on the slide. So like PVCs, our P wave is going to be invisible. It's going to be buried in that QRS complex. Since the P wave is missing, we're not going to have a PR interval. Again, there's no PR without the P. And the QRS interval will also be wide and distorted, so think greater than those 3 small squares. So essentially what you're going to be seeing is just ventricular activity on the ECG, so only QRS complexes. You're just going to be seeing a lot of them because, again, it's a tachycardic rhythm. So the causes of VTAC. Now, a lot of these are going to be really similar as what caused those PVCs. So think about abnormal electrical pathways in the ventricle from structural damage to the heart or lack of oxygen to the heart muscle. So this can be things like MI, that myocardial infarction, coronary artery disease, as well as cardiomyopathy. Again, we can also see this result from electrolyte imbalances. So potassium is always the one we're most worried about, but it can also result from hypomagnesemia. And we can also see it result from drug toxicity like digoxin toxicity. We know digoxin has a pretty narrow therapeutic index. It's a high alert medication, so we have to be really careful when we administer that. So our treatment for VTAC. Now this depends on our client presentation. If we have a stable VTAC, our client still has a pulse. There's no evidence that our cardiac output has been decreasing. Remember, we have a problem with our ventricles, and they are what's responsible for that big squeeze of the blood out of the heart. For these clients, we're going to work on correcting the dysrhythmia with medication. So we may give antiarrhythmetics like an amiodarone, maybe a lidocaine. If medications are not effective, then we're going to perform cardioversion. Now, cardioversion is performed with a defibrillator, but there's one key difference between cardioversion and defibrillation. And I'm going to ask you guys what this is. So what button must be engaged on the defibrillator when you cardiovert? Bonus points if you guys can share why, but what is one button you have to make sure is engaged to make sure you are not defibrillating, we are cardioverting? And if you don't know it, no worries, but if you do, drop it in the chat, let us know. Alrighty, I'll give you a few more seconds. And also, you do not have to spell it right. I never expect anyone to have to spell anything right. Some of these words are so long. Alrighty, but it looks like you guys got it per usual. You are doing so well today. I know this is tricky stuff, but that sync button is what I was looking for. So the answer is the sync button. The reason that we have the sync button engaged when we cardiovert as opposed to defibrillate is that the machine is going to find the rhythm of the R's and sync up so that we deliver the electricity at the right time to reset the heart. If this button is not engaged, it can fire at the wrong time and send the client into VFib, which we know can be fatal. So this is the treatment for stable VTAC. Medications first, our least invasive interventions, then we cardiovert if needed. Progressing along our spectrum of severity, we can also have VTAC clients who are unstable, but they still have a pulse. So these clients are going to start to show those signs of decreased cardiac output. This may look like dizziness. They may have a change in mental status. We're not getting enough output and oxygen to our brain, and they can even experience heart palpitations. So treatment for these clients will be immediate synchronized cardioversion. We're going to jump straight to that cardiovert option. So with stable VTAC, we went from least invasive to more invasive with medications than cardioversions. But for unstable VTAC with the pulse, we need to bring out our heavy hitter right away and make sure we synchronize cardiovert these clients to prevent anything worse from happening like VFib or pulseless VTAC. Speaking of pulseless VTAC, lastly, treatment for these clients is going to be immediate defibrillation. So we're not cardioverting a pulseless VTAC client. We're going straight to defibrillation because, again, there's no pulse. We treat pulseless VTAC like the way that we treat ventricular fibrillation. We defib VFib. We also defib pulseless VTAC. So no sync function for these clients. There's also one major thing that we also need to be doing for a pulseless VTAC client. And I'm going to ask you all in the chat, what is that other thing we should be doing for this pulseless VTAC client? So we already established that we need to immediately defibrillate them because there's no pulse, but there's something else in the meantime that we should also be doing. Does anyone else know what that is? And I see on TikTok, Hilda Joel already got it. CPR. Yeah, there's no pulse, so we need to make sure we're trying to keep that perfusion. We're trying to manually stimulate the heart to beat. We're giving that CPR. We need to deliver these chest compressions to get oxygen to these clients and follow those ACLS protocols. Alrighty, so great job, you guys. You guys nailed that one. Again, it's tough because we have unstable VTAC, and then we have our stable VTAC, unstable VTAC with a pulse, and then pulseless VTAC. So you have to do a slightly different thing for each one of these steps, but you all did so well. So with that being said, let's move on to VFib. So we're getting pretty scary into a pretty dangerous dysrhythmia here. Again, this is the last of our ventricular dysrhythmias that we're going to cover today. We already know that those PVCs that we talked about are a precursor to VTach, and VTach is a precursor to VFib. So when we get all the way to VFib, things are not looking good, and let's talk about why that is. So when we have VFib, our ventricles are quivering, and essentially they're completely disorganized. You can remember that VFib vibrates, which is sort of what this strip looks like when you see it on the slide. So I think we have two examples displayed on the slide here. It's disorganized. It's hard to find beats per minute here. It's completely disorganized activity. When we have a quivering ventricle, we're not going to have sustainable cardiac output, and that's a really big, dangerous thing. When we don't have that stable cardiac output, we don't have perfusion to our vital organs, and we know that this can be fatal. So when we look at this strip, what we see, or at least what I see, is chaos. And I see someone on TikTok said, chaotic. You are absolutely right. We're not going to be able to measure the heart rate from the electrical activity that we see on this ECG. We're going to see an irregular rhythm and no atrial activity. So no P wave, no PR interval, and not even a QRS interval, so we can be able to count our beats per minute. Essentially what we see is the unraveling of our heart's function. So pretty scary. This is a very high acuity patient. Our causes of VFib. So these are going to be a lot of the same ideas as VTach. Think about some abnormal electrical pathways in the ventricle, and this can happen from structural damage to the heart or lack of oxygen to the heart muscle. So think like MI, coronary artery disease, and cardiomyopathy. Again, we can also see this from electrolyte imbalances. Of course, that potassium hyper and hypokalemia, but we can also see it arise from hypomagnesemia. And when we talk about lack of oxygen, think about extremes. So like metabolic acidosis, for example, this may be things like renal failure or DKA that leads us to this. And it can also be caused by drug toxicity, specifically digoxin toxicity. So we have to be really careful when we administer digoxin because it has that narrow therapeutic index. All right, so now to our treatment. And I see some guys already are absolutely spot on. DFib, VFib, you are right. So VFib is pulseless. It's a non-perfusing rhythm, which can lead to cardiac arrest. So the basics of what we do, CPR, again, they're pulseless. Anytime a client is pulseless, we need to do CPR. We also want to defibrillate them. We defib, VFib. So we want to see if we can restart the electrical activity of the heart. We also want to make sure we're giving medications like an epinephrine or an epi and amiodarone. And we want to give our supplementary oxygen. So we're also going to need to get an advanced airway in these clients. So most likely intubation is how we're going to do that. And then we want to make sure we correct the underlying cause, whether that's an electrolyte imbalance or maybe that's acidosis. Alrighty, so all in all, we defib, VFib, and whenever the client is pulseless, we're always doing CPR. So now we are up to our final dysrhythmia of the day, and that is going to be AFib. So this is a really, really common dysrhythmia. A lot of people live asymptomatically with this. In AFib, the name really says it all. It is atrial fibrillation. So our atrium here are glitchy, our signals are not coordinated, they're weak, and our atrium are moving independently of one another. So our ventricles are getting mixed signals from there. We are essentially just out of sync here. But in the big picture, because the atrium are not fully contracting, it causes the blood in there to kind of swirl around and pool a little bit, which is a big reason for why these clients need to be on anticoagulants. So on an ECG, we're going to see an irregular rhythm. And I know that sounds kind of confusing, but irregular means we're going to see a quivering or a fibrillatory P wave. Because of this, we're not going to be able to accurately measure that PR interval, but the QRS interval is going to be okay. It's going to be less than 3 small squares. So our causes of AFib, typical causes include things like underlying cardiac disease, hypertension, heart failure, cardiomyopathy. A lot of the things that we've already discussed can be causes of other dysrhythmias. Also, we can also see AFib from anything that causes excitation, like a thyrotoxicosis, that thyroid storm, alcohol intoxication, lots of caffeine, which I know I am an offender of that one, electrolyte abnormalities like potassium or magnesium again. We can also see AFib from hypoxic conditions. So OSA or obstructive sleep apnea can cause this, as can acute conditions like a client post-CABG, because this can interfere with the heart's electrical circuit. Another common cause of atrial fibrillation will be older age. As time goes on, that sinus node does not function normally and waste products can accumulate in the heart, which will then cause dysfunctions. Alrighty, so talking about treatment for AFib. So again, pretty common dysrhythmia. A lot of people live with this every day. Medications are going to be our first line treatment when it comes to AFib. So rate control medications, including things like beta blockers, calcium channel blockers, and digoxin will be really commonly administered for this. We also want to make sure we have rhythm control medications like an amiodarone if needed. And all clients with AFib will need to be on an anticoagulant. So why is this? We brushed on this a little bit earlier, but that swirling of the blood in the atria, that pooling of the blood can cause clot formation. That blood is together, it can aggregate or clump together and clot in the atrial appendage. And the damage here and the scary part here is these clots can embolize and move to our brain, to our lungs, cause a stroke, cause a PE. That's really dangerous. So common medications we'll give are like a rivaroxaban, maybe an apixaban, just to make sure we're minimizing the risk of clot development. Beyond these medications, our clients may require cardioversion. So it's the same idea as before. These clients have a pulse, so we don't need to defib them by any means, but we hit that sync button before we cardiovert these clients. If that doesn't work, or maybe it's happened a couple of times and we're no longer able to do it, ablation is another treatment. Essentially, a healthcare provider will go in and zap, so to speak, the area of the electrical malfunction to treat this AFib. But again, we always start out with our least invasive method and then work our way up for an AFib client. Alrighty, so that was a lot of information, but you all did so well. So we now have 2 NCLEX style questions to go ahead and ask you guys so we all have a chance to test our knowledge. So question number 1, the nurse is assisting with cardioversion for a client with supraventricular tachycardia who has become hemodynamically unstable. It would be a priority for the nurse to, option 1 is sedate the client, 2 is select the energy level, 3 is charge the defibrillator, and 4 is turn on the synchronize function. Drop those answers in the chat. Let us know what you all are thinking. I see someone on TikTok is testing on May 29th. Good luck. You're going to do amazing. Keep letting us know as well when you all plan to test so we can wish you good luck. Or if you have already tested so we can congratulate you. I see someone else on TikTok is May 13th. That is so exciting. Good luck. Alrighty. Someone says tomorrow. Brianna on TikTok is testing tomorrow. Good luck, Brianna. That is nerve-wracking, but you're going to do great. Stay calm. Be confident. You're going to absolutely knock it out of the park. Someone else on Instagram is May 29th, and someone else on May 6th, and a May 25th. Wow, this is a busy testing month. Well, best of luck to you all. You're going to crush it. You're in the right place after all. And with that being said, I see lots of answers coming in, and the good news is I see almost all correct options. Hopefully you guys learned something today. So correct option is option number 4, turn on that synchronize function or the sync button. Okay, so it's sync supraventricular tachycardia, SVT. I know we didn't talk specifically about this, but this is a challenge of NCLEX questions. It challenges you to apply your knowledge in a broader sense. So VTAC needs to be cardioverted, not defibrillated. So sync button is going to allow the machine to pick up on the heart's existing electrical activity and deliver the shock at the right time. We don't want the machine to fire at the wrong time and send that client into VFib. So again, we want to turn on that sync button. We are making sure we are cardioverting. We're not defibrillating in this case. Alrighty, and question number 2. Here we simply have a strip, and I want you all to take a look, see if you can, maybe you need to count the QRSs, maybe you need to look for your P waves, and tell me what dysrhythmia you believe this is. I'll give you a little bit of time. I know it's hard to count all those little boxes, but again, we are showing you guys 10-second strips. So let us know what you believe this to be. I believe we use the same strip in one of our slides today, so hopefully it looks a little familiar to you all. And a reminder that we go live a couple of days a week now. We've added new evening lives, which is so exciting. But we're now going live these Tuesday lecture sessions at noon Central. That has not changed. And then on Wednesdays, we'll be back with question drills at 11 a.m. with Nurse Jackie and 7 p.m. with Nurse Andrew. So an evening time for all you night owls. On Thursday, we're back with myself at 11 a.m. and 3 p.m. with Nurse Incoli. And then now we have a new Friday live. We did our first week last week, but Nurse Andrew will be going live on Fridays at 7 p.m. and we are so grateful for him. So tune in for that in case you are at school all day or at work all day and are not able to join in or join for very long in the middle of the day. Alrighty, well, good news, you guys, you nailed it. VTAC is what we are seeing here. We're really only seeing ventricular activity, and it's a lot of ventricular activity, but it is regular, so it would be VTAC. If it was completely disorganized, then it would be VFib, but it still is a regular activity. Alrighty, great job, you guys. So in closing, thank you so much for tuning in today. This is a pretty long live, so thank you for hanging in here. ECGs are pretty difficult and pretty complex. My best tip for this is just to put the time into studying them. That's going to be how you get more familiar with them. But again, you will see them on your NCLEX, so it's an important thing to study. I hope you enjoyed our ECG interpretation lecture. Now let's put that knowledge to the test with an ECG strip question drill. Up next.
Hi everybody, welcome back to UWorld's Next Gen NCLEX review session. My name is Jackie and I'm a nurse here at UWorld. We're so glad to have you guys with us today. We are going to be covering ECG questions today. So if you're new to these question drill sets, what you can expect is we will pull up a question, we will spend about I'll give you guys about 30 seconds to answer, and then we will walk through why the correct answer is right. We have a lot of ECG strips to show you guys today, so something a little different than what we've done in the past, but we'll walk through it all together and make sure you guys have your questions answered. And be sure you guys use the chat today. Drop your answers in the chat. We have Nurse Samantha moderating, and she is there to answer any questions you might have. So be sure and share this session. Follow us on your favorite channel. We're almost at 50,000 followers on all of our channels, so help us reach that goal by the end of the year. Again, thanks for joining us, and let's go ahead and get started. All right, question 1. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, atrial fibrillation, option 2, ventricular fibrillation, option 3, ventricular tachycardia, option 4, sinus bradycardia. All right, 30 seconds on the clock. Drop those answers in the chat. Again, if you guys are just joining us, we are covering ECG strips today, so talking about different dysrhythmias. Share this session if you know it can be helpful to some of your nursing student friends. Again, we want to make sure and grow our UWorld community. It's a great community to be a part of, so we're excited to do this question drill set for you guys today. All right, I'm seeing a bunch of good answers, so well done, you guys. And let us know too in the chat where you guys are coming from. We love to see where our viewers join us from. All right, so our correct answer is option 1, atrial fibrillation. I don't have the number on here, so I was trying to remember where it was in the countdown. But again, option 1, atrial fibrillation. Okay, so what we're seeing on this strip, we are seeing an irregular rhythm. So that's kind of the hallmark of how you can remember or identify AFib on a strip. We're seeing, if you kind of break up the activity of the heart between atrium and ventricles, we're seeing really fibrillatory P waves, which represent that electrical activity that's happening in our atrium, that electricity that it takes to power up our atrium to move blood from our atrium down to our ventricles. So we're seeing a lot of disorganization in our atrium, and in turn what that's going to look like actually in our heart is going to be kind of a pooling and a swirling of blood in our atrium. We're not going to get a full squeeze in our atrium to move all that blood from our atrium down through our ventricles. So that's going to cause or increase our risk of clot formation formation, especially the atrium have like a little appendage in there, and that's really kind of the culprit or the place where that clot can form. So when we have a clot, one of the first places that can go in our client is to our heart, or to our heart. It started in our heart, to our brain. So we worry about risk, an increased risk of stroke for these clients. So knowing that, I'm not going to give you like all of the details of AFib because we have another question down the road that relates to AFib. But again, just think about that swirling, pulling blood, high risk of clot formation, high risk of stroke. So, but again, what we're seeing a regular rhythm. We're still seeing organized in the way of present ventricular activity, which is those QRS complexes, but we don't have a measurable PR interval, and we have just kind of a glitchy or like a vibrating, fibrillating atrium. So good job, you guys. All right, question 2. The nurse is caring for a client who is short of breath and is experiencing the cardiac rhythm in the ECG strip shown below. Which of the following actions should the nurse take? Option 1, administer an IV fluid bolus. Option 2, prepare the client for synchronized cardioversion. Option 3, instruct the client to bear down. Option 4, prepare to administer IV push atropine. Okay, so I want to tell you guys, the strip that you are seeing is a 10-second strip. So if you are wanting to know what the heart rate is for this scenario, which would probably be helpful to know to answer the question, you're going to count the QRS complexes and then multiply that by 6. So again, 10 seconds times 6 is going to give us 60 seconds or a minute. So if you have here 9 QRS complexes, you're going to take that number and multiply it by 6. So 9 times 6 is what our heart rate is going to be. All right, so knowing that, sometimes you'll see 6-second strips, sometimes you'll see 10-second strips, but I want to give you that heads up. This is a 10-second strip on this question. So if it was a 6-second strip, you would multiply by 10, but vice versa for this situation. All right. Okay, so knowing that, let's pull up our correct answer. So our correct answer on this one is going to be administer IV push atropine. So I kind of gave you guys a lot of hints, but our heart rate on this strip is 54. So what we're seeing here is sinus bradycardia. And with sinus bradycardia, our heart rate's going slow, but it's also, this client is symptomatic, so they're short of breath. So we know if our heart's not pumping quick enough or not perfusing those vital organs, and we're starting to show some symptoms. So a lot of times when we're treating bradycardia, we're going to start with like the basics. A lot of times bradycardia is brought on by medications, maybe becoming too high in our blood. So one of the first things we're going to do is discontinue those medications. So think about things maybe like a beta blocker. The next thing we're going to do is give a medication like atropine. So atropine is going to help stimulate our heart rate. It's going to increase our heart rate. After that, we would do transcutaneous. So think cutaneous is like skin, transcutaneous pacing, so like external pacemaker. And then after that, we would do an actual pacemaker. So a device that's going to take over the electrical conduction for our heart and make sure that we're stimulating our SA node to beat appropriately and kind of interrupting any of those mixed messages that might be happening. So again, what we're seeing in the strip is sinus bradycardia. In terms of the strip, what we see is a largely going to mimic just regular sinus rhythm. So we have a PR interval for every QRS complex. They're regularly spaced. The PR intervals are appropriate, so 0.12 to 0.2 seconds. The QRS complexes are 3 ticks, so you can remember QRS is 3 letters. They should be 3 ticks on the strip. And again, what we see in that PR interval, that's like the electrical activity or the kind of the power or energy needed to move blood from, or to squeeze our atrium. So you're moving blood from the atrium to the ventricle, but our ventricles are responsible for perfusing our body. So that that electricity, that conduction that needs to happen needs to be a lot more significant. So that's what that QRS complex shows us, like kind of pictorially. So we need a lot more energy to contract our ventricles because that blood has to go a lot further. So that's what the QRS complex represents. So I hope that's helpful. But again, atropine is going to be what we're going to do for this client with sinus bradycardia. What we see in option 1, administer an IV fluid bolus. This would maybe be what we would do for someone that has tachycardia, maybe from like dehydration. Option 2, synchronized cardioversion isn't going to be the fix for this client. And then option 3, instruct the client to bear down. That would be something we would do for like SVT or supraventricular tachycardia. So hope that's helpful. All right. Let me make sure everyone's doing okay in the chat here. How'd everyone feel about that one? That's kind of a tricky one, but again, just remember that was a 10-second strip. We had 9 QRS complexes, so 9 times 6, 54. Okay, question 3. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, ventricular tachycardia, option 2, atrial fibrillation, option 3, ventricular fibrillation, option 4, sinus bradycardia. All right, let us know what you guys think. Good work, you guys. Oh, and congrats to our viewer on there that is just past your NCLEX. I missed your name because it went super fast, but this is my favorite question to ask. If we have any new NCLEX passers on there, let us know in the chat. We would love to celebrate you guys. And if you have passed your NCLEX and UWorld was part of that journey, we'd love to know it on your social media as well. We also have a cool tool on uworldnursing.com where you can like record a little testimonial about how UWorld helped you or share any study tips to kind of any nursing students coming up, getting ready to take their NCLEX. So good luck to our viewer on TikTok that's taking yours tomorrow. You're going to do great. Very good, very good. And as always, we hope you guys can share this session and follow us, help us grow our UWorld nursing community. All right, good work, you guys. Okay, so our correct answer on this one is going to be ventricular tachycardia, or option 1. So you guys did great on that one. So what you're seeing here is kind of like a sawtooth pattern, but VTach essentially is our ventricles have kind of taken over the electrical activity of our heart. So they've swallowed up that PR interval. We're only seeing ventricular activity, which is what we're seeing here, just a bunch of QRS complexes, but they're wider than they should be. We're also seeing a lot of them. So this is going to show us that our heart rate is going to be greater than 100. So again, the wide QRS complex kind of indicates that there's something's wrong with our ventricles. They're firing too rapidly. They're overtaking the kind of electrical activity of our atrium, and they've kind of just taken charge of the whole heart instead of working in tandem with the atrium. But one thing to know with VTach is a precursor to VFib. So if our client is in VTach, we need to be very alert to this because VTach leads to VFib, and we know we defib VFib. So VFib is a life-threatening dysrhythmia. So when we see VTach, this is an alarming finding. We need to make sure and intervene. All right, so good job, you guys. All right, so question 4, moving right along, halfway mark. And if we need to zoom in on this one, just let us know and we can do that. All right, the nurse is observing continuous cardiac monitoring for assigned clients. Which of the following cardiac rhythms would require immediate follow-up? And we have 4 options in 4 different strips. So be sure you guys put your answer in the chat. Good luck to all of it looks like there's a lot of people taking your NCLEX in the coming week before Thanksgiving. That's very exciting. Good luck to you guys. And you can obviously celebrate with a nice big yummy meal on Thursday if you're here in the States. So very, very good. Good luck, you guys. And come back and let us know how it goes. We want to celebrate your big wins. So that's awesome. All right, so we'll let you guys answer. I'm seeing a bunch of right answers. You guys have done great. And again, if anyone's just joining us, we're going over ECG strips. And just a note about the ones we picked. So these are all noted in the test plan for the NCLEX. So if you guys don't know, the NCSBN who makes the NCLEX has a test plan, and it's really like a blueprint for what you can expect on the NCLEX. So these are some of the rhythms that they suggest knowing, and so those are the ones we're focused on. And we have a live and learn lecture on demand that really takes a deep dive into these. So be sure and check that out on any of our channels, and you can find like a good 35-minute kind of lecture going over some of the big rhythms to know. All right. So our correct answer on this one is going to be option 4. So what we're seeing in option 4, we kind of alluded to when we talked about VTAC, but what we're seeing here is VFib, or ventricular fibrillation. So essentially we're kind of seeing like the unraveling of the electrical activity of our heart. We're seeing like the ventricles are quivering. You can kind of like relate it to what we were seeing with the atrium or atria quivering with AFib, but this is the ventricles. And again, the ventricles are really what's pushing that blood out to our, pumping it out to our body, our perfusion. So we know that this kind of disorganization in our ventricles is going to lead to big problems. So again, when we see VFib, we know we need to defib VFib. So again, this is life-threatening. This is our priority. What we're seeing in option 1 is atrial flutter. Option 2, we're seeing sinus tachycardia. And then option 3, we're seeing PACs, or premature atrial contractions. So good job, you guys. Again, those are all options 1, 2, and 3, dysrhythmias to monitor for, to keep an eye on, but nothing that's immediately life-threatening like VFib is. So good work. All right. Question 5. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, ventricular tachycardia, option 2, ventricular fibrillation, option 3, sinus bradycardia, option 4, atrial fibrillation. All right, let us know what you guys think, what you're seeing. Good work, good work. You guys are doing awesome. And some of you guys are wondering if this will be posted. We will post these sessions later today on all of our channels, so you guys can go back and practice. Pause us if you need to, zoom in on anything. But again, we really encourage you guys to check out some of our on-demand content. We cover a lot of the kind of big, heavy-hitting ECG strips and dive into like how to identify them, what causes them, what interventions we can perform to help reverse them or treat them, in any type of like client education, things like that. All right. Good work, you guys. Good answers, good answers. Okay, so our correct answer on this one is going to be ventricular fibrillation, which is option 2. So again, we kind of talked about this, but what you're seeing here is kind of that unraveling of ventricular electrical activity. Our ventricles, again, responsible for perfusing our organs, our vital organs. If that's starting to unravel, we're going to have major complications. Again, we're going to intervene by defibrillating ventricular fibrillation, so defib, VFib. So again, I hope that's helpful, but what you're seeing here, there's no P wave, so we're not seeing any type of electrical activity in our atrium. There's no QRS interval. Everything's unraveling. It's very disorganized, not predictable. When we're treating clients with VFib, essentially what we're going to do is, if they're pulseless, so like meaning that the heart still has some electrical activity, but it's not enough to generate a pulse in our, periphery, we're going to start CPR. We want to make sure we're perfusing our organs. That's the whole point of CPR. Then we're going to defibrillate. We can give medications like epinephrine and amiodarone, and then oxygen, of course, to be sure that we're supplying our blood with oxygen the best we can. So good work, you guys. You did awesome on that one. Okay, question 6, moving right along. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, atrial fibrillation, option 2, sinus bradycardia, option 3, ventricular fibrillation, option 4, ventricular tachycardia. All right, let us know what you guys think. Good answers coming in today. And again, we're so glad to have so many of you guys with us. It's great to have you guys here, and be sure you follow us on our channels. And if you haven't yet, check out uworldnursing.com. We have our event schedule on there, so it kind of gives you like a few weeks in advance of what live content we're going to be covering with our times and channels that we're live on. It also has a lot of great links just to general resources from UWorld, including our free trial and then links to our subscriptions as well. So we hope you guys will check it out. And just a note, we will not be live next week for taking the week for Thanksgiving. So we will miss you guys, but we hope you guys can enjoy some time off and relax as well. All right, good work, you guys. Okay, so again, this is a 10-second strip. So what we're seeing here is 9 QRS complexes. So 9 times 6 is going to be 54. So we're seeing sinus bradycardia. We kind of talked about this again previously, but when we see sinus bradycardia, that sinus is going to kind of indicate that you can kind of think of it like sinus rhythm, which is a typical normal expected rhythm, but it's just slow. So we have a PR interval to indicate our atrial activity. We have a QRS complex that's appropriate. So those 3 tick marks. It's organized, predictable, spaced out appropriately. It's just slow. So again, our interventions for that, we're going to discontinue any medications. We can give amiodarone, and then we can do transcutaneous pacing, and then eventually a permanent pacemaker to help kind of stimulate that SA node to fire more frequently. All right, good job, you guys. All right, question 7. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. Which of the following medications should the nurse expect to be prescribed for the client? Option 1, epinephrine. Option 2, atropine. Option 3, rivaroxaban. Option 4, lisinopril. All right, let us know what you think. Oh, I saw someone just pass. Oh, congratulations to our viewer on YouTube who just passed your NCLEX. That's amazing. Congrats. That's the best part of our job, is getting to know that UWorld was part of y'all's journey to passing the NCLEX and getting to celebrate, and very cool. And if you guys have passed your NCLEX, let us know what kind of nursing you're going to do. If you're heading to like a hospital, a clinic, travel nursing, any type of specialty, let us know. We love to hear all of that. Awesome, awesome. Good work, you guys. All right, I'm seeing a good mix of some options, so we can walk through this one a little bit more. Okay, but our correct answer on this one is going to be option 3, rivaroxaban. So what we're seeing in this ECG strip is AFib. So again, we're seeing kind of typical expected ventricular activity, which is that QRS complex. But what we're seeing is like fibrillatory, kind of unpredictable atrial activity. So that's how we know this is AFib. We have an irregular rhythm. So we don't have a PR interval for every QRS complex. Things are spaced out a little bit. It's not quite lining up. So that's how we know we have AFib. Again, we talked about AFib. It's going to kind of cause like our atrium to be glitchy. We're going to have like a pooling of blood, kind of a swirling of blood that can generate clots, especially in that atrial appendage, like kind of like a little peninsula in our atrium. And the blood can swirl around in there and form a clot. And we know clots can dislodge, head to our brain, cause a stroke. So clients with AFib need to be on lifelong anticoagulation to help lower that risk of stroke and lower that risk of clot formation. So rivaroxaban is that kind of medication. Epinephrine wouldn't be appropriate for AFib. Atropine, again, we would give for bradycardia, and lisinopril is going to be an antihypertensive medication. All right, good work, you guys. Question 8. The nurse is caring for a client who is experiencing the cardiac rhythm in the ECG strip shown below. The nurse should recognize that the client is experiencing option 1, atrial flutter, option 2, atrial fibrillation, option 3, premature atrial contractions, option 4, premature ventricular contractions. Very good, you guys. Drop those answers in the chat. Last question. Let us know what you think, and when we're done, let us know how you guys did out of the 8 questions. Very good, very good. And if you guys want a bonus point, you can let me know what you would do for a client experiencing this dysrhythmia. There's a lot of different things. Maybe this wasn't the best question to give you a bonus point on, but I wanted to make sure you guys could get one. So let us know what you guys think. Good work, good work. Good answers, everyone. All right, so our correct answer on this one is going to be premature ventricular contractions. So essentially what we're seeing on this, we're going to have a little bit of an irregular rhythm. We're going to have wide distorted QRS complexes. So essentially that QRS complex is going to like swallow that PR interval. So it's going to hide the electrical activity happening with our atrium, and it's just going to show that electrical activity happening with our ventricles. So again, we're going to have a variable heart rate. It's not going to be consistent, an irregular rhythm, and not consistent PR intervals. So one PVC is not anything to kind of be too worried about, and it can even be expected anytime we like mess with the heart. So after like a procedure, like heart surgery or cath or something like that, we would expect our heart to be a little irritated, and that would kind of be what a PVC would show us. If we start to have more frequent PVCs or PVCs in a row, that's where we're going to get concerned. So if we have 3 or more, we would consider the client have progressed from like just having PVCs to having VTAC. And we know VTAC is a precursor to VFib. So that's where we really want to keep an eye on these PVCs. We want to watch them because if they're happening more frequently or if they're happening consecutively, that's where we're going to worry again about that transition to VTAC and then VTAC to VFib. So that's kind of why they're important to know. But a lot of times with one, we're just going to monitor, we're going to watch. But again, that kind of concludes this. We hope this was helpful.
Thanks for tuning in for our ECG greatest hits today. Come back tomorrow for more of our most popular videos.